As Trevor indicated earlier, we partnered with HP. We took these tablets to the presentation as well, because a lot of the clinicians we've worked with have found they want to use portable devices, and they're moving ahead more quickly in some ways than we are. So we've needed to get our applications working on devices like tablets. We're now looking at cell phones and other forms of portable devices. And the clinicians really love these, and I'm not sure how many of you have actually played around with the application here. We're actually showing the full concerto demo that I talked you through very quickly here is running on this application. And this is the client server that we've got here. Sorry, client server that way. So we have the PACS image here. We can turn that around if you want the screen real estate to be this way. And it's very light. I don't know, it'd be about half a pound of butter. It's a New Zealand expression. And if you want to actually write some notes, there's also the same sort of applications that you have running. You can scribble some notes here, so adjust somebody's medication. So you could actually be doing your ward rounds using these devices, and then you simply plug it in. This one has about a 6-hour battery life, I've discovered, thankfully. And so you can take these with you. Your clinicians can be using these, and it's running the same application that you have there on a desktop. So it's really enhanced the ability for the physician's handwriting. Yeah. Well, it's reading my handwriting. I can log in. So it's a real challenge. Probably what I haven't shown you, and you really need to get quite close up to look at this, is there's a wee area here that will appear, which is the pen. It actually shows you a wee input panel, and you can have your input panel as a keyboard or as a writing pad, so you can just simply scribble what you normally scribble there and then go send, and it basically either accepts your writing or it doesn't. And I found it's very user-friendly for me, and I have appalling writing, so I'll just pass it on. I've been typing for so many years now, I've actually forgotten how to write. So for those of you who have clinicians in your organisation who really don't want to sit at a PC for a start, or learn to type, I think these are really going to revolutionise the uptake of electronic health record. So
we'll continue to pass it around, and
I'll get it
so everybody will have an opportunity to look at it. We are videotaping this session, as you know, so at the end of this session we'll be videotaping the use of this tablet, and it will appear on the videotape, which you can see from our website.
Okay.
Probably 2 weeks from now when we get this presentation on the web.
We'll do as well. The microphones are moving around and things. We'll any questions? I do have an extra recorder here for people who want to make a comment. Trevor also is apparently an expert at repeating the question. If anybody wants to make a comment, they can take this from me. Any questions or comments from anyone?
I'll speak loudly.
Just if you're going to make a comment, we won't hear you otherwise. But it's just a quick question.
Just a question.
Okay.
You mentioned that the basis for the centralized data repository is based on an 8L7 schema, and I'm curious if you can comment on the flexibility there to be able to manage larger data types like radiology images and structured reports and that type of thing.
I knew I'd need the guy from Oracle. One of these I'll use. The clinical data repository at this time doesn't and is not intended to handle images. That's typically what a PACS repository would do. So you've got hundreds, thousands of images stacked there. So certainly, say you took the Orion solution, as I said, the icing on the cake, it would go against the data repository to bring up the patient data about that patient, and then would go against the radiology repository, in this case, to bring back the image, and still bring those into the same clinical context for the physician. Does that make sense?
Yeah, that does.
So in essence, you've got two different repositories working at that point.
So in order for it to have a type of a system where a physician, let's say, at hospital A wants to see images for, and I'm the patient, but I have images scattered across a number of hospitals, it would require still PACS infrastructure that was designed to be able to facilitate that
Right.
process.
So when you think about the Oracle Clinical Data Repository, you've got to think about HL7 version 3 RIM, because that's really what it is. So the data context for that repository is HL7 version 3 RIM. So if you go into HL7 version 3 RIM, you'll know exactly what's, from a data perspective, what's in there.
Well, as you ask your question or give your comment, please state who you are and where you come from. I promised I would do that for everybody. I know you're from Mitra.
Yeah, my name is Chris Meidel. I'm a product manager for modality connectivity.
Okay. Questions and comments? Back here, question or comment?
My name is Marcia Agate from London Health Sciences in London. I have a question, and the question is around the management of the data repository. I understand the concept of bringing all the information from the legacy system, but I'm interested in understanding how you normalize that data and manage it on an ongoing basis. What does it take?
It's not insignificant. And
Question.
do you want to repeat the question? What does it take to manage the data within the clinical data repository on setup plus on an ongoing basis? So certainly on setup, there is a significant amount of effort required to map data from all your disparate clinical systems that exist today. This is your immunization, inoculation, vaccination kind of scenario to that concept. But that's really a one-time mapping, right? So you take your definition in whatever immunization systems you have and you do that one-time mapping. But even over time, it's not insignificant, but it's not that complex to manage the data within the repository. So there is probably a slightly different set of skills that you would need in a London Health Science Centre, data management skills specifically to manage that data. You may have some of that today, but you'll probably need a little bit more of it. So most of the effort is actually in the initial mapping of the data. And then any changes that you may have in your underlying systems, that continual mapping.
So do you see in a healthcare setting a group that manages that? Do you see that becoming a support, operations support group that would be required?
Well, certainly, do we see that as the question was, do we see an operations support group being set up in health organizations to do data management, basically, in this kind of context? Certainly with the organization we're working with, it's a combination of internal people that they have, plus some private sector people from firms such as ours. That's how they're working through it. Do you want to add anything?
Typically our installations, we don't have long, ongoing come back and help us type relationships. We're more of a product company, so they would build that capacity within their own organisations.
Does that move to Canada Health Employee? And my question has to do with your model. Basically, you're replicating information throughout the repository. There's a natural latency between the time information is generated and the time it hits the repository. What is the risk of physicians making clinical decisions with possibly outdated information in that repository?
Right, so the question is, there's a potential for a time lag between the time the data is entered in a clinical system, it's placed in a repository, and how could that potentially impact a clinician and their clinical decisions. Is that fair? Okay. So, certainly from the data entry point of view, the data is entered. How you then orchestrate the messaging from that source clinical system and the timing of that messaging is up to you. And so you could have real-time messaging coming out of your clinical system, going into the repository, and viewable through an Orion clinical portal. That's possible today. So really the timing of your data will be dependent on your infrastructure, the kinds of applications you have, those kinds of things, as opposed to a technology issue of being able to do it versus not being able to do it. Okay? Anything else?
Other questions?
One question about the electronic health record as a concept. What is your philosophy in terms of who owns that record, and how do you decide what is appropriate access?
So the question is, what's our philosophy, which I can answer real quick. What's our philosophy around who owns the record and who can access the record? The weasel way out of this for us is we don't have a philosophy on this. It's really the client that has the philosophy. So, but in actual fact, that's the truth. So, and there's two aspects to this, I guess. One is the privacy side of things, and one is the security side. Privacy really is being decided today in public policy, whether that be at a federal level, like the PIPEDA type legislation, and it's typically in law, or if you go down to provincial level, like certainly in Alberta, it has a Health Information Act, or even if you go to a local level where it may be just privacy policy development and implementation that people have done locally. So that's sort of the legal / policy process that our clients would undertake. The translation of that then into security mechanisms to protect personal health information based on who can access it, the need to know, those kinds of things. The one that we can certainly talk to very easily is Alberta, which has a Health Information Act in place. I don't know whether you've taken the opportunity to read it. Don't read the Act itself. There's actually some supporting documents with it that are very easy English, and you should read it because I think it's probably one of the most pragmatic implementations of privacy security I've seen within a healthcare setting. And certainly from a security perspective, both the Orion and Oracle clinical data repositories, we've had no issue about being able to step up to the role-based requirements around who needs to know what for what purpose and meeting the intent and actually the specifications of that particular act. Yeah.
I have a question related to Paul Brown, a small consultant from HealthNext. Your early comments about your system, the last remaining Canadian. One could argue that the architecture around this goes beyond IT and into the competitive model and the regulatory environment. Here in Ontario, there's a policy, the Ministry of Health, it does not fund hospital IT systems. In BC, the Ministry of Health has a strategic plan for health information management in British Columbia. How do you enter and penetrate this market and talk to that value proposition when you have a large segment say health information is not funded, doesn't in fact add value to health services? In other smaller provinces, yes, we have a health plan. How do you market as a corporation? How do you actually commercialize something like that?
So how do you commercialize, I think the question was, how do you commercialize an offering such as we have presented today from Central Station Consortium when different customers, different provinces are proceeding, one at different speeds and in different directions? I think is that fair? Yeah, okay. Certainly it's one customer at a time. I think, and there are different kinds of customers. So when we look at, say, a Western Canadian situation where they have regional health authorities, the provinces are quite involved, and there's certainly in a lot of these provinces a lot of impetus to do things in a common way. So the number of customers there are not as large as, say, an Ontario situation, which is a larger number of health organizations, some of who are wanting, and today you'll see opportunities on the street today for companies like ourselves to respond to for exactly these kinds of solutions in Ontario. But there are different organizational setups, different kinds of technologies than what we may find in other parts of the country. So it's really defining, clearly understanding who your customer is, what their needs are. It's the same, and they're just different types of customers in an Ontario setting versus Western Canada and actually versus Atlantic Canada. Does that make sense?
Questions or comments from over here? Okay. Back and after the floor.
Jane Cardinal, I'm just on the entry community health informatics at the University of Brighton to do a PhD. My interest then is in health as much as it is in the medical side. But looking at your product, In the previous question, how do you see this product being useful by a consumer, by a patient, particularly, say, one with a chronic condition, and say we have a policy and how the Health Protection Act that allows them to use the electronic health record for their benefit to help monitor their condition. Can you speak to that?
So the question is, how does this type of solution enable consumers to participate in managing their health record or accessing or looking at or being part of the care process around this health record? I'm going to hand that one over to Sarah.
We've looked at that, and certainly from a technology perspective, the patients could have access to that portal. They're just another user with different access rights, so they will obviously not be able to look at other patient data. They were just looking at their own record, or even just part of their own record. Whether they're able to update their own record, well, that again remains to be worked out with the organisation whoever leads into this. I've also looked at a number of other solutions out there for patients, and there are some in Canada right now that are very good, where people are able to update their own information for diabetes, and I can share some of that with you later. And I have heard even in the last few days where patients who perhaps aren't very technically competent can be getting updates or reminders via a telephone, by automated telephone. So there's certainly a lot of technology out there that you can use and pull together with this. We're not the only component here.
This one down here. Did you have your hand up before?
Yeah, Joyce Becker from Grand River Hospital. I'm interested to know how many sites, how many places are actually using this today. I mean, it mentions in the information about, Capital Health Region going to be working with this. But I'm just wondering, like, either as an individual group of hospitals or regionally or larger.
How long have you got? Just generally, we would have over 20 installations of Concerto worldwide. We probably have, that equates to around 6,000 clinical people that are logging into Concerto to access information. That's of the rough order of magnitude. Now, some of those sites are just straightforward hospital installations. So probably around a third of them would be straightforward hospital access to lab results and so forth. And a number of others are anything from a national immunisation register. This product with the disease management component has been rolled out nationally in New Zealand, child health immunisation. And in the UK we have regional health solutions. So one of those is called Warsaw and Birmingham, and they have not only access to the lab results and so forth, but they also have community-wide integration of care plans.
I think there was one more question down here, then I'll go to that.
My name is Tommy Dodd. I'm a retired consultant of policy and information, and I'm particularly interested in a discussion with respect to EHR and the differentiation of that with EMR. Many physicians are making a distinction between an EMR and an EHR, and how you would see your database interfacing with what one would call an electronic medical record.
Do you want me to handle that one? So this is a question that wanted us to differentiate between an electronic medical record and an electronic health record, and how would we see the data within an electronic medical record interfacing or becoming part of an electronic health record. Is that fair, Don?
That's the access rules related there.
Okay. I'll define the electronic medical record, and you can correct me if I'm wrong, as the data that a physician would collect and keep within their physician office. So it's the electronic version of the paper records that would be in a physician's office today. Is that fair?
Plus what they generate in their clinical practice if they're practicing in a hospital.
Sure. Any lab results about that patient or that may come in. Okay. So, and if you think of the Ontario setting, there'd be a very large number of those physicians and electronic medical record potentially systems. So that's the electronic medical record. electronic health record spans the continuum of care. So it's not just physician-based care, not just primary physician-based care or specialist physician-based care. So it spans, as we indicated earlier, and might have been just prior to you coming in, Don. I saw you slipping down the stairs there. It includes, it includes long-term care, public health, what would be community care access centers, hospitals, plus physician offices, plus community lab, community DI, community pharmacy. So bringing all that, plus whatever else is out there, that's a simplified view of the world, into a single record. This diagram here, you'll notice, and I know you didn't see it originally because I noticed when you came in, and you promised you wouldn't have any hard questions for me. Really, this is the notion of an EMR down here in a physician practice. In this particular architecture, which is from one of the provinces, they are going to put, or are planning to put, discussing with the Medical Association to put, those electronic medical record data into either 1, 2, or 3 provincial type repositories. So it would hold that. And then, of course, the electronic health record layer sits over top of that, which would be your end-to-end longitudinal type information. The electronic, certainly the application that Orion has, and you can speak a little bit further to this, Sarah, because in New Zealand today they have the same situation where they interface between the Orion layer at the top and the physician's office EMR. So if you want to speak to that.
Really, coming from the New Zealand environment, as I said earlier, before you slipped in, New Zealand GPs have automated way before some of the other hospitals could send data to them. So they've already invested and developed their own electronic medical record. There initially were probably 15, 20 vendors. Some of them were physicians who created their own systems. And now there are probably really about 5, 3 of which are significant, and they have added all the various components to complete what the physician needs and adapted to the local environment. Whenever there was a medical insurance government change, they could adapt their software accordingly to meet the needs of their client base.
Maybe talk about health and the number of physicians.
And separate to that, there is a service that has a little bit of synergy with smart systems or WellNet, those types of systems, and that runs across, it's a network or virtual private network for health, and that's probably enabled a lot of the uptake for physicians, and that if there wasn't that infrastructure in place sending all these messages, then they probably wouldn't have adapted as quickly as they had. So, and that has like 99% coverage of physicians, all labs, and most of the hospital laboratories as well.
Could that be
Okay, go ahead, John.
It's up more on the continuity of care and a multidisciplinary care environment, particularly case management. How much interaction there is between, let's say, the data repository as representative of your model versus an EMR, and the notion that the doctors might also be giving orders to diabetic management or whatever it might be. So that interaction and continuity of care.
I ask you to use the microphone and be careful when you're having trouble hearing. Oh, you're playing with your microphone. Let Sarah do the nervousness.
Sarah, I was actually going to show you a little bit of the data. Can I do that? Is that okay? I'll just leave him here again. Or we could show you on the... let you know if I pull any of those facts out for home. It may be easier to show you on the tablet. Certainly it would have been quicker.
By the way, there are an awful lot of people named Graham on your database. Sarah?
There's also a lot of Sarah's in New Zealand as well. So we have here... So we have here the typical information that might be involved with chronic care, and this information could be collected by a number of different providers. Some of the community users may be collecting this information. And typically in the New Zealand installations, the GPs have already been collecting this in their own systems. So what we do is we populate this data, or the repository that stores this data, directly from those systems using that secure health network that we talked about earlier, HealthZone. So they're already capturing that information, and it may be somebody else using another clinical system elsewhere that helps populate that information, not directly into this form, but through to the repository.
But that's open system, you say?
Standards. So the key thing to this is standardising the data that you want to capture and having published standards between the vendors, so you all agree that we're going to call, it doesn't matter what you call it because you can map the data. You basically agree on what you're going to collect and ensure that it's being collected in the same way and format in those other systems.
Okay, one question in the back there, and then maybe if there any over here, I'll switch over. So,
I was just wondering if web services have used as backend integration solution.
Sorry, could you repeat?
Services have been used as backend software integration.
what is your back-end integration technology? Or can you give an answer to that?
Orion actually came into the health space with a toolkit called Symphonia. And it's a messaging toolkit. Now, we built the HealthLink network on that product. We've also developed mapping products around that. So we would use what we call our back-end integration suite, and that also includes the data engine as well, so full-on data integration engine.
I think she'll speak to
Any questions? No, I think there's still questions. One in the back.
Do you have any implementation that's using HL7 version 3 right now?
Not at this point.
The question was?
Sorry.
The question was, do you have an implementation using HL7 version 3? Maybe just in a little bit of response to your question. The Oracle data repository basically takes the data in the latest version of HL7. I think it's 2.5, I think it is. And then has a message processor that converts it to a version 3 that can populate the database. So the Oracle repository, to a certain degree, is independent from the messaging in and out of HL7 version 3 and has its own processor to do that. Maybe back to the previous gentleman's question as well around the back-end integration. There's a number of techniques that are used in the Orion technology that you might want to talk to.
So you saw the initial summary data, the documents and so forth, and that came from the clinical data repository. We also can interface in a number of other ways. We have HTTP scripting for web-enabled applications, and the data that the data that came from say the Oracle HTTP would have been interfaced by Java API.
CCAL.
Services, stop messaging protocol, nothing?
Not so.
No, not so.
Okay, and there's another question here.
Following this lady's question regarding regional implementation, where is Canada in terms of, you used Alberta as an example in your presentation, where is Canada in terms of moving towards this by province? Who's leading and where is Ontario fitting?
I didn't hear that question. So where does Ontario fit in vis-a-vis the other provinces in Canada around electronic health records? That's a leading question. Certainly each of the provinces, and let's come back a little bit to some of the drivers for electronic health records in Canada and some of the sort of federal context for that, or the national context. So there was certainly all the provinces, territories, federal government agreed on this tactical plan that focused on electronic health records. There was originally, I think it was 500 million and now another 600 million. CHII was set up. And if you look at the CHII business plan, I think one of the directions clearly in there is for each of the provinces to develop their architectures. So And you'll see many of the provinces have initiatives underway today to do that. Not just Alberta, but certainly most of the ones that certainly I interface with in Western Canada or Atlantic Canada, and even in Ontario, there's architectures that have been developed around provincial approaches to health IT and electronic health records. So those are sort of in place today. The next step, of course, is implementing those, and those are affected by a lot of different factors. Politics being one of them. By politics, I mean small p, large provincial politics in terms of where governments are at, how much money they can put in place, where organizations are at locally, how far they can move forward. Certainly today there is a major push on in Alberta. There's no two ways about that. So you can look at Calgary, Edmonton, and the rest of rural Alberta, and they've set some timelines in which to implement. As for the rest of Canada, including Ontario, they seem to be moving at sort of the next sort of layer of speed, if you want. And you're starting to see, for us anyway, opportunities coming up in each of those areas, whether it be Atlantic Canada or Ontario here, or even in BC.
We have time for one very brief question or comment. If not, just a few reflections of my own on your talk. Knowing you guys just came from Alberta, when I saw one of your slides, POS, to me that meant point of sale. And I thought that fit in with what's going on in Alberta right now. But I realized in my position off the systems, I was relieved, very, very relieved. It was kind of interesting hearing the names for your products, the Concerto and Soprano, and I'm wondering if you're going to want tenor, and that's going to go on. And anyway, it was all music to our ears, and we really appreciate you being here. And I want to congratulate you for an excellent presentation. It was a really enjoyable time. Thank you.